a hot minute, so it's nice to see her computer screen. It's being recorded. Got it. All right. Well, we can go ahead and get started since we are at 12:01, and I know folks have places to be at 1 on the nose and patients to see and other meetings to go to, so we can get things rolling. But hello, everyone. Welcome to our monthly alumni webinar. Please feel free to introduce yourselves in the chat and provide your contact information in case you'd like to connect with other alumni from this afternoon's discussion. I will throw mine in there really fast so you don't feel alone. So remember that chat feature is at the right of your screen, but you might have to click the button to see it pop up. I'm Rachel Frisch. I'm one of the adjunct faculty alumni ambassador who works very closely with Sam Weiss to make these awesome webinars happen. We previously last year did them monthly and wanted to see how we can consolidate and make sure that we can get the most optimal attendance from alumni, both on campus and off campus in the community. So we figured, like, let's change up the timings to see if people during the business hours could attend more regularly, because we know, myself included, people with kiddos, people at home, pets, got to get home, and that rush hour meeting was a busy one for many folks. So hoping that this session can be interactive and get the most faces and people in the same space. I totally understand if you want to have your videos muted. I'll have mine on the whole time, but if you need your video because you're chewing or whatever, that's perfectly fine. But also, keep in mind, it's casual, so it doesn't matter what you look like. This is come as you are. It doesn't matter if you're not working today in PJs. I don't care. Remember that this event is supposed to be interactive, so we really do want people to post questions and respond to questions that are thought-provoking or contribute with your experiences of what you're seeing. The entire goal of the monthly webinar series, which is now, I think we're going to do it every other month or quarterly at times, is really to get people together. We have so many amazing alumni at UNC, and many of which are on faculty, still on what Gary calls like the mothership, right, on campus, but so many more are out in the community across different states and doing amazing things. So the goal with this program is really to kind of unify what we're doing and still keep alumni in all parts of the world up to date on what UNC is doing as far as innovative research and programs, but also too so that we can learn who is taking new patients, what programs are offered at other facilities from UNC alumni, because we know we are highly trained folks and we're damn good at what we do. And we want to make sure that we continue to collaborate in ways that allow our patients to succeed and to do well. And I think, I mean, as always, we do better when we're working together, even if we're no longer working in the same space, which is heartbreaking for me, having transitioned from full faculty to adjunct. But this keeps my toe in the pool at UNC, and it's really fun to meet other faces who I haven't seen in many years also, who've left the mothership. So please feel free to communicate, put yourself off mute if you have questions, but otherwise keep yourself on mute if you do have noises in the background. Today we are very lucky to be joined by the wonderful Don Rosenstein, psychiatrist, and Lauren Lux, social worker, who are from the Comprehensive Cancer Support Program. Their roles within this program are tremendous, and if you trained at UNC through residency or fellowship, you are likely to have interacted with them on the Consult Liaison service or in any other capacity, learning about how large the cancer center is at UNC. And having gone through this process recently with a loved one who we recently lost to cancer, more timely than ever, because this is something that is going to face many of ourselves and many of our patients in some capacity or another, that we will have to learn how to best manage medications and individual psychotherapy, family therapy approaches with cancer, medications, and just in general experience the process of going through this. So your experience is worth its weight in gold in terms of what you guys do at UNC, and it's, from what I can see, not replicable anywhere, because my family member went to MD Anderson, and there's nothing like what we see at UNC, and I found that the hard way the first time around. So would love to learn more about what you guys are continuing to do at UNC and enlighten us with how we can work together or learn from you and replicate that in some way.
Thanks so much, Rachel. I'm real sorry to hear about your father-in-law, right?
It was.
Yeah. Sorry. Hi, everybody. It's nice to see some familiar faces and names. I am going to delay introducing Lauren for just a few minutes because I want you to hear a lot about the program that she runs. Lauren Lux is the director of our Adolescent and Young Adult Cancer Support Program, which I think is the leading program in the country, if not the world. I think it's they've done remarkable things, and I'm going to let Lauren talk about that in a minute. But what I wanted to do first is kind of orient you, kind of a "you are here" map, and then take you on a quick reconnaissance flight through the Comprehensive Cancer Support Program, so that if you have any particular questions and you want to kind of get down to the ground level and walk around and do more of an exploration in detail, we will do that. So it'll be kind of quick. Very briefly, I have been at UNC for, this is now my 13th year. I spent 17 years at the National Institutes of Health, where I worked with our former chair, Dave Rubino, where I got to know our illustrious training director, Karen Dawkins. When she was a fellow there, we were maybe 1 year apart, I think. I'm not going to tell you who's older. And the intramural program at the NIH is a really interesting, wonderful place, and I think one of the best uses of taxpayer dollars. We can talk about that too if you want as we go on. But I was recruited here to start this cancer support program. So let me first make a comment about the organizational structure of the department in case you haven't heard it. I'm going to tell you about 4 divisions within our department, 4 subdivisions within my division, and then very, very briefly, the 9 different components of the cancer support program, of which the adolescent and young adult program is one. So the 4 divisions are what you've probably seen or heard about. There's the Division of General Adult Psychiatry, which I direct. There is the Child Psychiatry Division. There is what happens at Wakebrook, and then Global Psychiatry, and Michael Zarzar runs Wakebrook, as you know, or probably know, and Karen Poulos is the Division Director of Child Psychiatry. And then there is the Division of Global Psychiatry by Brad Gaines. Within the Division of General Adult Psychiatry, there are 4 units. The largest one by far is the Consultation Liaison service, and we serve patients at the mothership, the medical center, UNC at the medical center, and also at Hillsborough Hospital. We do consults telemedically. But starting in the next 3 to 6 months, we will be doing telemedicine consults to a number of the emergency departments and medical and surgical floors in hospitals that are a part of our ever-growing healthcare system, UNC Health. So there are now 18 entities across the state, and most of them do not have consult services and have either no or very limited psychiatric availability in their emergency departments. And so we are trying to figure out how to serve the state from Chapel Hill, and the pandemic and the growth of telemedicine has made that more possible. So again, the 4 components of the Division of General Adult Psychiatry are the Consult Liaison Service. We have roughly 60 to 70 patients on our list at any given time in a 850-bed hospital. A second component is the substance abuse program, which is led by Robin Jordan, and which is growing substantially, but still understaffed, underfunded, I think, given the opioid epidemic. And that's really been pressing a lot of people lately. The third group is interventional psychiatry, which is ECT and TMS. Karen Dawkins ran that for a long time till she recently stepped down from that, and Rob McClure is now running that. And we're also doing ketamine and brexanolone and other interventions. We're moving towards psilocybin kind of clinical and research studies. And so maybe in future conversations, we'll have a chance to talk about some of these other components. And then there is the 4th group is the Comprehensive Cancer Support Program. So the very short version of the CCSP, which has 9 components, is that we started this from scratch about 13 years ago when I came here. And at the time, there were 2.5 FTEs, a kind of nurse practitioner and a social worker and another nurse. And we now have about 33 people in the CCSP. So we've grown quite a bit as the Cancer Center has grown, with a lot of support by the Lineberger Comprehensive Cancer Center and the North Carolina Cancer Hospital, which opened up about a dozen years ago. And just to name them, the different components of the CCSP are the Patient and Family Resource Center, which has got all sorts of books, reading materials, counseling, a boutique for hats and wigs and scarves when people lose their hair during chemotherapy, and a lot of educational programs that go on there, as well as community outreach and patient navigation. We have a psycho-oncology clinical service where we see inpatients and outpatients, composed of a few psychiatrists and a couple of psychologists and social workers and nurses, and master's prepared counselors. We have an interesting financial assistance program for people who experience financial toxicity related to their cancer care, where we provide a lot of direct financial assistance and also a pro bono legal clinic. We have a nutritional program with 2 dedicated outpatient oncology dietitians. We have a caregiver program, a survivorship program, exercise and wellness, and a statewide engagement and research program as well. And so I can tell you about several of the clinical trials and research programs that we have. And then finally, the AYA program. And so I'm kind of leading up to Lauren in just a minute. But what I would tell you is that the way that we've tried to build this is to create a really solid clinical infrastructure and then overlay on top of that training opportunities. And then finally, research kind of activities that are funded from the National Cancer Institute and other institutes of the NIH, all the way to foundations and local programs. And so when you think about the CCSP, I hope what you think about is anything other than chemotherapy, radiation, surgery, and immunotherapy. Now, we don't do all of the supportive care services, but we have a hand or a relationship in those. So, for example, genetics counseling is part of the Department of Genetics, and they serve the whole house, not just cancer. And the chaplains serve the whole house, not just the cancer hospital. But we and social work, the social workers don't report directly to me through the CCSP, but we had 0 social workers when I started. And Lauren, how many social workers at this point do we have in the group? We've got 5. So we've been hiring social workers as fast as we can, and we're hiring 2 more. So we have dotted lines of relationships with a bunch of other groups, but and to be perfectly honest with you, just to emphasize that the CCSP ends in a P. It's a program. It's not a center, either with a capital C or a small c. It's not a department. It's not a division. It is a program. And on our very best days, I think we are well integrated and highly functioning. And on our rougher days, it sometimes feels like we're held together with duct tape and a little bit of glue. Because we have people employed by the School of Medicine and the School of Nursing and the School of Public Health and different departments within each of those schools. And some people are on hard money, and some people are on grant money, and some people are on kind of, gift funds from grateful patients. But somehow we are making it work. And I think we serve the people in North Carolina and their caregivers who have cancer well. So at this point, I want to pivot a minute and let Lauren tell you about the latest member of the CCSP family, which is only 5 or 6 years old. And before Lauren starts telling you about what it is and how it came to be and what she does, I'll tell you that This is a real jewel in the crown of the CCSP, and she will be too modest to tell you that our program has been a model throughout the country for how you attend to the needs of people who are in that developmental moment where they're no longer kids, they may not be fully independent adults, and they need to have very specific needs addressed. So it's my pleasure to turn this over to Lauren Lux, who is a licensed clinical social worker and was the founding director of the Adolescent and Young Adult program and an adolescent whisperer. So Lauren, tell people about the AYA, if you would.
Thanks, Don. I think you left about 100 things that you do every day out of what you talked about, but we probably would need more time than we have allotted for you to go through all of that. But I want to ping for later because you do such a good job of this for everybody else when you introduce everybody else, the widowed parents work that you guys are doing that isn't just unmatched, and some of the really cool research that you're doing that I think folks would really like to hear about. So I'm going to play you right now and just remind you that you really need to talk about all the other cool stuff that you do too. Don does such a good job when he introduces us to other people. As many of you probably know, if you like see Don in the hallway and you're talking to him and somebody walks by, I can see some of you on the call that he's done this to me with, where he's like, person, meet this cool person, and then he's your hype man and tells this other person all about all the incredible things that you're doing and vice versa, and it just feels very good, first of all, but second of all, he absolutely deserves that to be done for him as well. So I'm gonna make him talk about some of those other things. I'll try and be short and sweet in talking about the work that I get to do because of Don. So thank you for having me on, and thanks for the intro, Don. I'll start by sort of giving you a little background of how we came to be, and also nationally what's happening in the adolescent and young adult cancer space. So the reason that we have a program is because of a local foundation whose name is the Be Loud Soapy Foundation. And Sophie Steiner was treated here at UNC about 8 years ago. She was a 14-year-old when she was diagnosed with the cancer, and a 15-year-old when she died, and really charged her family with this idea that we need to take better and different care of teenagers and young adults. And so the Steiner family, Nicholas and Lucy, and their daughters, Annabelle and Elsa, created this foundation to honor Sophie's memory and to do that really important work. The beauty of Nicholas and Lucy is that they really understand how systems work. And so they knew from the just kind of from the jump that they wanted to hire somebody within a system who could help create some broader change, as opposed to operate as a family foundation that sits outside of a system that tries to help patients within that system. So I was hired with funds from the Be Loud Soapy Foundation. Around the same time, there had been this sort of groundswell of energy and movement in the oncology world, and people were starting to recognize, largely from some pretty big data sets, that in the last 30 years, the survival outcomes for adolescents and young adults, which are defined as the ages between the ages of 15 and 39, that their outcomes were poorer than their pediatric or adult counterparts, and that the reasons for this were largely multifactorial, and we needed to sort of drill into why is this happening? Why is this age group struggling? So as Nicholas and Lucy and the Be Loud Soapy Foundation was beginning and our program was starting, the timing was really nice, because elsewhere in the world, there's been more and more attention paid to this patient population. It's become sort of a subpopulation within oncology, its own subspecialty. And so we were really fortunate to benefit from Be Loud, and also sort of just the timing of what was happening in the world. So as Don said, we started our program 6 years ago. It mirrors CCSP in that sort of three-legged stool approach. We have a really robust clinical care team that sees patients between the ages of 15 and 39. We have a research arm, and we have a training and education. And I would sort of add outreach arm as well, as we think about how can we create this sort of hub and spoke model, where we have a lot of intense resources here at UNC Chapel Hill, where we see about 450 newly diagnosed 15 to 39-year-olds every year. But also those other young adults specifically who are treated at other UNC sites or elsewhere in the state? How do we make sure that they're getting what they need as young people, as we know that their medical and psychosocial needs are unique, and that there are some pretty simple ways for us to meet those and improve their quality of life and their survival outcomes? So our team consists of myself, my medical director and partner, Andrew Smitherman, who is a med-peds trained pediatric oncologist, and he is a physician scientist and does a lot of research around early aging in cancer patients and survivors, as well as survivorship care. So we have an AOA survivorship clinic where we'll see anybody. They don't have to be treated here at UNC for survivorship visits, which it's been a really cool initiative. We have a clinical social worker who does the bulk of our clinical care. We operate as a consult service, but we're a universal consult service. So your only ticket in the door to us is your age. So if you're between the ages of 15 and 39, we want to see you. And her counterpart is a nurse practitioner, which she joined us at the beginning of COVID. So, and is one of about 10 AOA nurse practitioners in the country. So that's just, every person that we bring on is in a role that is new to them, but also largely new sort of in this space. So there's a lot of building the plane as you fly it that we do every day, just sort of trying to figure out what this is going to look like. So our nurse practitioner and our social worker lead that consult service. We have a fertility preservation social worker who meets with patients before treatment to talk about family planning post-cancer therapy. We have a research assistant who joined us last year, a palliative care doc who's with us part-time, who works on this program that we have with our young adult sarcoma population. It's a joint visits that we do with our AOA team, the palliative care folks, and our sarcoma team. That patient population has a really high symptom burden and a really tough, often treatment course. So that's been a really cool program that we've started. And I'm forgetting someone. No, I'm not. Yes, I am. We have a new member who is our medical oncology liaison, which we're really excited about. Smitty, our medical director, lives in the Department of Pediatrics. We always knew that we needed someone to be the bridge on the medical oncology side. And so at the end of the day, I think our mission is to improve quality of life and treatment outcomes for adolescents and young adults with cancer who are served by a system who is not built to meet their needs. They're either teenagers treated in the pediatric world, and that's not unique to UNC system. That's systems everywhere. They just don't have a home that fits them. So I think we try to stand in the gap where those systems aren't necessarily able to meet those needs and try to create new processes and systems to then get those folks what they need. And that looks really different for every patient. And we try to do that again on the individual level, but all the way up to statewide engagement. We host a symposium each year for providers in North Carolina that we partner with Wake and Duke to try to, again, sort of bring everyone's education level up. We're sort of aiming to change the culture around us, not just sort of churn and burn through each patient and have us do all of that work. Everyone just needs, I think our goal is to give people the tools that they need, providers the tools that they need to sort of put a different pair of glasses on when they see an adolescent or young adult patient, so that they're looking at them through the right lens. They're asking the right questions. They're thinking about the right things that are age and sort of developmentally appropriate for that person, that will then facilitate their ability to engage in their cancer care in a way that their outcomes will be better. So we're really lucky to be extremely well supported in the cancer hospital and by Don and by the Department of Psychiatry. And there are so many people who have come together to make this happen over the years. Our team, both within the institution and in the community, feels so big. We feel so lucky to be supported in so many ways. And our next really exciting thing is that we're building space. So we are creating young adult focused infusion space up on the 3rd floor of the cancer hospital, where anybody between the ages of 18 and 39 who are receiving their treatment outpatient, which more and more cancer care, especially for our age group, is happening in the outpatient space. they're going to have their own space. So they come to a separate check-in desk. They have a separate waiting area. And we're building this big, beautiful space that was really designed by our young adult patient advisory board. So they've worked with us over the last 2 years to create this space that they have deemed a coffee shop in the woods. So that is the theme of the space. And it's all sort of natural colors and a really interesting like flow of the space. But with the idea that even if the space looked exactly the same as everywhere else in the cancer hospital, being co-located with others that are the same age as you will reduce that feeling of isolation, will foster connections in more spontaneous ways. Like we do a lot of matchmaking right now. We're like, hey, 20-year-old Hodgkin's patient, do you want to meet another 20-year-old Hodgkin's patient? And as you can imagine, that doesn't feel great to everybody. But if you're sitting in a waiting area and you're only surrounded by other young people, we anticipate that those connections will happen in a much more spontaneous way where we take ourselves out of the middle of it and they can just talk to each other. And so we are super excited to be able to transform the space and give our patients and their partners and caregivers and friends a home that they can connect with each other through. So those are kind of the fun, exciting things that we have on the horizon, and I'm happy to answer questions. And also please make sure you make Don talk more about the cool stuff that he's doing.
We are, thanks, Lauren, that was wonderful. And we are comfortable with silences and space, and we wanted to leave lots of it so that we could have a conversation. So what did we, in that kind of flurry of kind of oversight, what piqued your interest?
So my question in the chat was about the space, right? Because UNC main campus is so tight for space right now, and I know they threaten to keep people out all the time from the actual physical space there. So exciting to see that they're actually making room for this and prioritizing it as something that's necessary. And it might not be traditionally revenue generating, a traditional coffee shop that's kind of a space for these patients, but it's necessary, right? A lot of what you guys do is in that wheelhouse, I guess, that might not be directly revenue generating. And I would imagine probably getting creative in terms of how you bill for some of the comprehensive care that you provide. But it is worthwhile for them. It's the quality of life is just incredible. Makes me expensive coffee. Quality of life is so much more improved. My question on that kind of is like, in terms of where some of these opportunities take place, this is such a large program, much larger than I knew of. Like there's so many more branches to it. Where do people generally access these services? And like, are there kind of hubs throughout the UNC locations that they're offering? Because I know, what is it, UNC, there's like that place in Cary that's kind of like a health and wellness center. I think it's UNC Wellness Cary. That strikes me as one of the more holistic type of comprehensive places that UNC campuses offer. Are those types of hubs where these kind of services are offered? Because the yoga, the massage therapy, what are patients getting these services?
Yeah, it's a great question. Some of it is decentralized, but most of it happens here right in the medical center. And there are multiple doors into the building. So when we first started this, like a lot of new programs, there was a lot of hype, and I got really anxious that I didn't want to overpromise and underdeliver. So we didn't really advertise for a while about who we were and what we did. We just kind of tried to grow organically. And as a result, we've got a website. We've got, I would say that the window to the CCSP is the Patient and Family Resource Center. So if you come into the North Carolina Cancer Hospital, on the ground floor, right next to the outpatient pharmacy, is the Patient and Family Resource Center space. And it's an inviting space. You walk in and there is navigation that goes on. Now, some people are just lost looking for the bathroom or the cafeteria, but a lot of people don't even know what it is they need to ask about when they're scared. And then they walk in and we've got staff there who can help kind of either a caregiver figure out how to navigate the internet and find out what is nonsense and what is real information, or have a quiet place to sit and have a conversation about kind of a need for counseling about sexual dysfunction or something else. So there is the foot traffic, there is the website, there are direct referrals from clinicians all over the hospital. One of the accrediting organizations for cancer hospitals is the American College of Surgeons has something called the Commission on Cancer. And in order to get accredited, and there are 1,400 cancer centers that are accredited, it's a little bit like the Joint Commission. One of their requirements is that you do systematic screening for psychosocial distress. This was something that the grandmother of psycho-oncology, Jimmy Holland, pushed really hard to do, which is essentially asking people, how are you doing? You know, and there are a lot of different ways you can screen for distress. The main one is to do a check. You know, there's a distress thermometer on a scale from 0 to 10 with a checklist, and you can ask whether people are having trouble with transportation or with pain or with paying their bills or with childcare or with dyspnea or with depression and so on. And then we use that as a way to try to triage who needs what. We bump into people in the hallways. And so there are a lot of different ways to get there. What we're really working on now, especially with these two new social work hires, one of them is going to be more of a triage navigator role, because sometimes people need one thing, but very often they need many things. And so it's hard to just do one referral to all the different services. And so what we're hoping will happen is that when someone is referred for a particular reason, there will be a brief conversation on the phone with this social worker who will basically get a sense of what they need. Now, our schedulers can't do that. They're not trained to do that. And we do a lot of touch passes to each other within the program, but we're going to try to be a little bit more systematic in how we match up patients' needs and caregiver needs with the various services that we have. In answer to your specific question, though, that was kind of related but off, Rachel, is that our yoga classes take place in the community. We have an exercise program called Get Real and Heal that is in a separate facility that's near where the old tennis courts used to be for the university. It's this really neat spot right on campus, and we've just renovated it. And it's brand new space. We're going to have a grand reopening soon. So if people are in active treatment, they can get involved with exercise. We do various programs virtually, like we have a cancer transitions program for people who come to the end of their active treatment. So it kind of, it's somewhat decentralized, but in these days more virtual than I would like. I mean, it's good, it's mixed, but what am I missing, Lauren? You do stuff that's out and about as well.
Yeah, no, those, I mean, I think the takeaway is that we're all over the place, and it depends on what service you're trying to, or it depends on what service you're trying to access. You know, for our program, we really try to meet people where they are. So we are not creating separate appointments for them outside of their existing oncology visits. So we're sort of roaming gnomes in that way. And when we have our infusion space, there'll be seven infusion bays, plus the coffee shop. So expensive coffee shop, but supported by 7 infusion bays.
I see Karen.
Yes, as someone who is no longer considered, young, I was interested in how you came up with that range, the 18 to 39. And my thought was, well, that can be a pretty heterogeneous group. Is a 20-year-old very much different than a 25, but certainly perhaps even more different from a 39-year-old as far as where they are developmentally. And I just wonder what kinds of issues come up. Is this group more heterogeneous, as I think they are? Yes,
Absolutely, 100% yes. We have to wear so many different hats all day. Sometimes we're talking to a mom of a teenager, and sometimes we're talking to a teenage patient, and the mom is the patient, and so we're definitely all over the place. So the age designation was a US designation. There are different designations in different countries and different systems. In the UK, teen and young adult cancer is largely considered 13 to 25. In Australia, it's 18 to 30. They sort of have different cutoffs. That designation in the US was largely due to the lack of improvements in treatment outcomes. So people got sort of bunched together because they all were experiencing that same disparity in terms of those outcomes. But yes, it is a completely different population. In addition, just developmentally to there being big differences, they're treated in two different systems of care. And so knowing what levers to pull in what system, pediatrics versus medical oncology, is a big part of the work that we do. And yeah, I think we see so many different needs depending on what's going on. I think one of the commonalities is often, though, there's a lot of transition happening at whatever developmental phase they're in within that group of people. And so there's not that steadiness that exists later in life in terms of when you have an illness that disrupts your life trajectory and what's happening in your life. You are not returning to a steady place. You are sort of in flux as you went through treatment. And then when treatment's over, the idea of what am I returning to and who am I and what does that look like looks really, I think that's something that's shared across that age range. Less so as you get a little bit older, but I think that's something that is common.
I'll just add one thing to that. So what's interesting about it is, so much of what happens in cancer is driven by the National Cancer Institute and a research agenda. When you think about even the name, a comprehensive cancer center, sounds like it's all about clinical care. That's actually a designation related to NIH funding, National Cancer Institute funding and infrastructure for research. So what's fascinating is that this became a priority for the NCI, just as Lauren said, because when you looked at the improvement in survival in different age groups, in my lifetime, we've seen 5-year survivals for children with cancer go from about 20 to 30% all cancers to over 80%. It's been phenomenal in terms of outcomes for children. And similarly, the adult and older adult groups have also gotten better with more precise clinical trial approaches. That 18 to 39 group didn't do as well. And it's a really interesting question scientifically about why, and it's multifactorial. To some extent, the biology is just going to be different. Getting certain cancers in your 20s is different than getting that same cancer in your 50s. It's not always quite so different, but in some cancers it is. But certainly there's a lot of adherence issues, behavioral issues that come into play, which is why Lauren's program is kind of so helpful at getting people engaged and keeping them engaged, because they don't have parents to make sure that they are going to make all of their appointments and take all their medicines at the right time. So but Karen, you're right. It's a very diverse group. And that was a challenge, I think, for Lauren and her team to kind of design space, that works for young people and not quite so young people.
Yeah. Interestingly, there was a big jump in improvements in earlier detection with Obamacare. So when the policy went into place where people could stay on their parents' insurance until they were 26, we saw a big jump in people's survival outcomes, which, is a vote for health insurance for as many of us as possible.
I'm sure it surprises none of us in the room, but it's amazing that we could see that fact.
Right.
Yeah, we can talk politics on this thing. You said it was informal, right? Medicaid expansion already. Enough. Let's do it.
I think we have 2 hands up. Emily, I believe, was first, and then Karen.
Even Indiana has Medicaid expansion.
Wow.
But and we're way behind North Carolina in many other ways. But I was curious if you guys could speak to the role of philanthropy, private philanthropy in this, and if it's brought any sort of unique considerations to what you do?
Don, you want to go first? Or you
I'll
want
go
me to-
first on that. It's such a great question, Emily, because mental health needs the kind of philanthropic successes that cancer has. Everybody kind of, in every cancer center around the world, from, like if you look in Boston, the Jimmy Fund at Dana-Farber just brings in an enormous amount of money. And you look at Sloan Kettering and MD Anderson, all the big places, philanthropy is huge. St. Jude's. So cancer is the 800-pound fundraising gorilla in the room. And I think everybody can and should learn from some of that fundraising. For us, it's critical to what we do. And so Lauren's program is funded entirely. It's funded by grants now, and there's some clinical revenue as well coming in, but it was started and principally funded by philanthropy. We have a program that generates a significant amount of operational revenue for us every year that allows us to do all sorts of things, pilot programs and so on. And so one of the interesting, I'll just mention one other thing and let Lauren go, but one of the really interesting dilemmas that we've had lately is that a lot of the funding that we get from the state to improve cancer care, and virtually all of the philanthropy that we generate, is for patients with cancer. There are some interesting non-cancer conditions that are treated by oncologists. And because hematologists cover sickle cell disease, patients with sickle cell disease are treated in the cancer hospital, and historically has been profoundly underfunded, under-resourced. And so occasionally it creates some tensions about, well, what can we use what money for to try to help different clinics and what they need. And we try our best to spread the wealth and the love as best we can, but there are certain constraints to what people give money for. And then the other last comment is that the needs that people have are very often closely related to cancer, and very often have nothing to do with cancer. Have to do with food insecurity, have to do with chronic mental illness and cancer, pre-existing problems. We just simply don't have the resources to be the community mental health center for everyone and their family member who have been touched by cancer. So we're constantly struggling with scope of services. When do we see people and for how long? And when do we try to refer people to the community, which is a mental health desert, as you all know, in so many ways. So that's my response. What do you got, Lauren?
Yeah, I mean, I would agree with all that. I think my take on philanthropy, or the perspective that I've developed over the last 6 years, is that it's incredibly powerful and necessary, but not as useful without institutional buy-in, and that the marrying of the two is where the magic happens, I think. And so we were started by funding from Be Loud, who currently still and historically has funded my role. But at this point, we have 8 people on our team and no one else is funded philanthropically. And we've used pilot funds from Be Loud. So we would go back to Be Loud in years 2, 3, 4, 5, 6 and say, hey, what about donating an extra $20,000 this year so that we can pilot this role that we're going to partner with these other people to try and fund and get some proof of concept under our belt, so that we can then convince the institution that this is a worthy endeavor and that it's safe to invest their money in this as well. And I think that's been incredibly powerful for us. And I'll add that it's also only as powerful as is the administration and the leadership here at UNC and in the cancer hospital and in psychiatry, recognizes the importance of the work we're doing and is willing to partner with us. And so I think when I talk to other programs around the country about how do you do this, like what does it look like to build an AYA program, or really any program, a big part of our success is that institutional buy-in that is then coupled with the freedom that we have and the flexibility that we have to use some of these funds, but that those funds won't last indefinitely. And even the most robust and committed philanthropic partners, that's usually not a forever thing. And so always having an eye on what's the sustainability aspect of this and what's the plan for the future has been, I think, a key to how Don has built CCSP and how we have built our program as well.
That's great. Thanks so much, guys. Karen, did you have your question? I think you're muted.
This is really helpful. Thank you. I'm learning a lot. I had a question for Lauren, and Lauren, it's good to see you. And
You too.
I know we've talked a lot, but I realized that I don't have, other than what you just talked about with the coffee shop, which I love, absolutely love that idea, the coffee shop in the woods or whatever. I don't have a clear picture of what you actually do with the teens that is different. So as you know, I work with teens, and so I'm really curious about what do you actually do that is different, that is specific for that age group, that's different than, older adults, teens and young adults, that's different than older adults and different than kids?
Yeah, that's a good question. I think my first response to that would be that it's actually not that complicated. There's nothing that's rocket sciencey about it. And Don, I think Don jokingly called us the teenage whisperers, but I'm not like that cool, and I'm just barely in that AYA age range. Like, it's not like I'm young and hip. And so I think that the approach that we take, I would say, is different in a few ways. Number one is that we have the flexibility to go to them wherever they are. We're not requiring them to come to an appointment with us to get any kind of services. Number two, I think largely we deal with a lot of adjustment to illness, psychoeducation, and sort of how this is just normalizing the experience for people by assessing early and often. So asking questions that are age appropriate questions in an age appropriate way. For instance, are you sexually active? What is that going to look like for you while you're in treatment? How can we help you navigate that safely? Who is your caregiver? Oh, you're 25 and your caregiver is your girlfriend who is also 25. What does that look like for you guys right now to navigate this process together? How can we support you with that? What education and tools can we provide you? So it's a little bit of a hybrid sort of social work, nursing, child life, navigation. We just sort of do a little bit of a lot of things, but I would say a bulk of it is just asking the right questions at the right time, because we know what that treatment process looks like and we're so familiar with that for that age group. Doing it privately, so making sure that we give people space to be young people, asking their parents or caregivers to step out of the room, giving them that privacy to have those conversations, ask those questions. We talk a lot about alcohol and drug use and where's the line between use and abuse, and how do you do that safely so there are specific subjects that I think are relevant to young people that we always have our eyes on. And then I also think it's just that interaction style, which is very non-judgmental, that we have a lot of time to build rapport, that we can try and build trust in a way that then we can have really hard conversations around end-of-life decision-making or advanced care planning with the 30-year-old that has kids and with the 18-year-old that's at home with their parents. So it's unique to patient needs, but I think there are some themes that are both topic specific and then I think just interaction style specific. And then the last piece I'll say is that I think we serve as mediators and translators in many ways. So we stand sort of in between the patient and the medical team who may not quite have their like AYA glasses on when they're feeling a frustration with someone with when they have trouble adhering to treatment, or when they're an 18-year-old who's been in the hospital for 3 weeks and the blinds are closed, the lights are off, and their covers are over their head. And people are like, what are we doing with this person? And how can we help them? We can sit in the middle and sort of mediate that in some ways. So that's what it looks like, and just as some examples of the clinical role that we can play.
Okay, that's really helpful. Thanks.
I love that answer. And like the basic premise of so much of what we do in whatever silo we're working in, whatever niche population we're working with, is asking the right questions and getting you in the door to actually have that conversation. That takes time, and it takes somebody purposefully doing that work. How do we get people into the room to be asked the right questions? So referrals, like I know Dawn had talked earlier about how like there's just too few of you and too many people who cancer has touched their lives in the community. Who are the appropriate referrals? How do we get them to you? And what does that process look like?
Go ahead, Don.
Anyone certainly who is receiving cancer care at the North Carolina Cancer Hospital can be referred to us. And if they have needs, should be referred to us. Additionally, we've seen patients receiving their cancer care at other places. They would need to get registered here as a patient first in order for us to see them. You know, we are increasingly struggling with kind of how much and for how long we can do what. You know, we just can't see people in weekly psychotherapy and medication management, you know, if they're not getting their cancer care here. But we'll do a consultation and then try to work with folks outside of here. As a general rule, we try to focus on people who are in active cancer care or in transitioning from active care to survivorship. That's easier to define that transition with some cancers than it is others, right? It's easier for most people who have breast cancer, for example. For the majority of women, it's going to be kind of a really hard 9 months to 1 year, followed by a transition to follow-up or maybe kind of hormonal treatments. But for someone who undergoes a bone marrow transplantation, they're swapping out a life-limiting condition for a chronic condition. And so there's never really a moment of survivorship exactly. And so it gets fuzzy. But as we follow, Lisa Park is one of the psychiatrists in our group and a really talented clinician and researcher. And we follow the Lisa Park rule whenever we can, which is when patients are seeing us more frequently than their oncologists, we start to think maybe it's time to, you know, get you somewhere else. So, but we're happy to at least do a consultation on anybody in North Carolina who is struggling with cancer and kind of coping with it, and with no necessary promises about who we're going to be to that person going forward.
And can I ask, are most of those initial consultations virtual right now? So I can imagine. Okay.
Most are virtual. And then that's been good and challenging. It's good because a lot of people, you know, the cancer hospital here serves people from all 100 counties in North Carolina. A lot of people would drive 4 hours from the eastern or western part of the state to get here. And then it really felt funky to try to provide their mental health care from here when they're so far away. We're doing more of that. The challenge has been that we've about tripled the number of patients that we see compared to before the pandemic.
And best way to refer is through the website, then I imagine.
Yeah, through the website, and or you could send an Epic in basket or call Robin Herring, who is the kind of executive assistant administrator for the CCSP, or write to me if you've got somebody.
I know Karen Dawkins also has a question we want to get to.
Yeah, I had a question about aging in and aging out, given those kind of parameters. And I also imagine that there's a difference between somebody who's 18 and 39 who is having a recurrence versus somebody who's having their initial diagnosis in that age range. So how do you kind of deal with the aging in, and after a certain point, whether, you know, they're in a normal transition or not, they age out of your program?
Yeah, that's a good question. I think generally speaking, we don't transition well in oncology. We sort of hold people forever and ever and ever. And so I don't think we're not any better at that than anybody else. I think we're constantly striving to answer that question. And I think so I don't have a great answer to that. We try to talk about it early. We try to, you know, send people to survivorship clinic. We try to make sure they're plugged into other services, all the typical transition stuff that you would think of. I think, and as it relates to what Don just said too, about how we transition people in and out of the services that we have with CCSP too, just around expectation setting with patients and families and how that works. And I think the thing that we're all feeling, especially right now, is just the context of the broader world that we live in and how under-resourced everything is, and that that matters for the work that we do too. And it makes it harder to transition people when there's nowhere to transition them, and the responsibility that we feel to them when there just isn't a good, soft, or at all place for them to land outside of our services. It's tough to cut them off. So I don't have a great answer really.
I'll add one thing to that, Karen. There's a happy story and a sad story about that as well, which is that there are a lot of people who have cancer. They have a really brutal time during the diagnosis and treatment, and then they're cured of cancer, and they can and will and want to move on with their lives. And if they didn't really have a need for mental health services beforehand, they may not need it afterwards, and they're happy to go on. And so they kind of, you know, that's in their rearview mirror, just like their first 3 marriages or whatever else happened in their life. And then there's the other side, the kind of tragic, sad side, which is the people that Lauren and her team get most involved with often have really bad cancers, and they die from their cancer. And so, increasingly have been helpful in end of life care and working with the palliative care teams and trying to figure out the best or the least bad place to die for some folks. So a lot of folks either get better and leave or don't get better and leave. And so it's not as big a number as you might imagine.
Tough stuff. And on that, I mean, I think I see a lot of patients of my own that are actually clinicians in the oncology world, and like, thank God for what you guys do, because that is hard stuff to witness day in and day out. So thank you for that.
It's hard. Can I leave do we stop at 1?
Yes.
Can I leave people with one thing? I'm going to take Lauren up on her invitation earlier. So one of the things we didn't talk about, and we can talk about another time, is the widowed parent program that we do here. And the reason that I think it's important, and I want to mention it to you all, is because the short version is that we've worked with individuals who have lost a co-parent to cancer, and now they're raising younger children on their own. And I think that work is important and valuable in and of itself. But one of my strong motivations to do that work is that it has provided for us an invaluable feedback mechanism for how we care for parents living with advanced cancer at the end of their life. And I don't think we do a great job with that often. And so we have learned from people who are eyewitnesses to how their loved one lived with and died from cancer, what we did right, what we did wrong, and what we can do better going forward. And the reason I bring it up is that I do think that compared to other industries, if you call medicine an industry or kind of domains of society, I don't think we have great feedback mechanisms built in. A lot of times after people get their medical care or their psychiatric care for that reason, and then they kind of go on, I don't know that we often ask people how to do our work better. And so that's just been an interesting project that has informed us in all sorts of ways about how we train people and how we work with people and what we ask them, and kind of just to try to do more holistic care. What are the things that are most important to you? You know, we're so focused on the tumor type or whatever else. And for a lot of people, it's like, how am I going to continue to be a mom while I'm going through all this? And how am I going to talk with my kids about kind of the fact that I very well may die? And so Lisa is working on an online tool for that she's testing that we think is going to be really valuable for people who have trouble accessing those kind of services going forward.
Lauren, thank you so much for those links. I read the book, but I have not seen the TED Talk yet, so that's going to be interesting. So important.
Justin crushed his TED Talk. It's really good. Check it out.
And really, too, it's like clinicians who don't do this type of work every day, to know the referral sources and to know who to send people to, and to know what, if there's nobody to send them to, how do we learn how to do this work ourselves? Like, it's tough stuff. I found myself last week Googling, you know, what do I tell my kid for brain cancer? A mom who was going under surgery, neurosurgery for some brain cancer. And she was like, I need resources. And here I am, just as naive on Google as she is. And it's unfortunate that it does have to feel like that sometimes. So again, thank you for what you guys do, because it's so necessary. I know we are a little bit over time, but today we are lucky to have Jillian in the space with us, who's at MD Anderson. So I don't know, sorry to put you on the spot, Jillian, but
I am so happy to be on the spot. Actually, it's my 5th year anniversary. I showed on Facebook today of finishing my med school rotations at UNC. So how convenient, because this is my why. Everything you stated is like what I live for in terms of helping patients. I mean, I want to do psychiatry. We'll put that back out there, trying to get back to UNC. But I know I will come back. My boss was texting me during this meeting, and I was like, okay, I just want to be there. So we'll navigate that in an email later. My patients are all head and neck cancer patients that have a really hard time with outcomes when it comes to xerostomia and inability to eat, chew, talk. Life is different, and then potential disfiguration from their surgery. So when I met them before I joined MD Anderson, it was from the stage of oral medicine, where their salivary glands are obliterated and I can't serve them. And they're so desperate for quality of life improvement. And I felt very hopeless, because I was like, you know, there's very limited ability to help somebody with that severe dryness of their mouth. And I saw how it affected them. And when I was young, I was inpatient on a unit for children. It was a pediatric oncology unit. So everything that you're doing, it was humanizing the experience. It was bringing us together. I didn't have cancer, but my treatment was on their same floor. And I was the one that went out and got this Denny Hamlin from the race car, and like the ability to just normalize the childhood experience. And it's the same thing I heard from a stage 4 cancer patient recently, who was a coach here, and his information's public. So this is not sharing anything that's not out there, but he had a stage 4 cancer journey. He's a coach. And what he brought to my attention was just how the experience, what he would recommend is just to try to humanize it more and hold space more, and sometimes just be a listener. And when I was at UNC, I found that I really craved the ability to learn how to speak to somebody at the end of their life. And I was able to do a rotation that was how to live a good death, is what I called it, and just dug into that research, like how do you even sit with people and have these hard discussions. So I just love the work that y'all doing. I love hearing what is being prioritized, because it's so valuable.
Cool. Hey, Jillian, when you reach out to me later, I want to get you. Do you know a guy named Nosayaba? I have trouble with his last name. Osazua Peters. He's a Duke. He is this very, very cool junior investigator from Nigeria. He was an oral surgeon in Nigeria. Now he's essentially an outcomes researcher at Duke, and I'm mentoring him on a K award. But he is particularly interested in psychosocial outcomes in head and neck cancer patients, and the particular problem of suicide, which is much higher.
That's what I'm doing. Yeah, that is exactly what I just proposed.
So I'll connect you if you don't know him. He's a really wonderful guy, and very enthusiastic. He's a character.
Yeah, I was an oral surgery resident when I was at UNC. So not
cool.
that is completely related, but sounds like a perfect match.
Yeah,
So
good.
thank you.
This is the Don hallway connection. You just got done.
I have been waiting for this webinar like every day. I'm just so excited about it. So thank you.
This is what webinars are for. Don, we do need you at pretty much every one moving forward, because that is naturally. But
You say when. You say when.
thank you all.
Thank you.
I appreciate everyone.
Thanks, everybody.
So great to see everyone. Thanks again for the great information
Thanks
today.
so much.
Thanks.
Good to
Bye-bye.
see y'all. Ciao. Thanks, Lauren.
Thanks, you